So really, this is the big thing that we do in psychiatry that's a little bit different. The mental status exam. On first glance, it really looks like there's a lot of different components to it, and there are. There are a lot of different parts, but a lot of it is just observed and then you make comments on it. So these aren't all related to questions. I mean, it's meant to be the physical exam of psychiatry. That's what I tell my patients, that I'm ready to do like a physical exam of their brain. Are they ready? Um, it's meant to be objective, right? A lot of this is our kind of interpretation of things, though. But is it really objective? When you ask a patient how they're doing, if they're in a certain psychosis, they could say something like, "Yeah, there's an axe in my back," and that's definitely an experience I had with a patient that was schizophrenic. Um, so how do you? The point I want to make on this example here is that when you're documenting a mental status exam, you really have to differentiate what you're observing as true versus what the patient is stating. And so a lot of times I put a lot of quotes in my mental status exams to kind of like make that distinction. So this patient that told me they had an axe in their back, I want to capture that, right? I want to capture the fact that the patient was saying that, but at the same time, I want to make the reader aware that that actually wasn't the reality of the situation. So there you go. And that was really interesting guy. So again, they are observations and inquiries of the patient that give a snapshot of what's going on with the patient right now, and that's important. Kind of an example of that is, if a patient that I might see at the hospital, it might be 3 or 4 days after they were first admitted, or 3 or 4 days after they were in the ER, and they were there for suicidal ideation. Well, if I ask them if they're having any thoughts of suicide or self-harm now, they may say no. And that's what I'll put down. But again, it doesn't change the fact that that's what they were admitted there for. So it's a way just to capture progression and monitor how patients are doing. So yeah, it's the major psychiatric portion of an HMP, and it's really meant to be the objective part of it. Um, you know, it's not the only part that we do. We still do the other components of the of an HMP, at least when we first meet the patients. Okay, so you probably won't get a full physical exam at an outpatient psych office, but you probably will get one if you're in a hospital setting, okay, and you're being admitted. But an MSC is definitely something that we do on every day that we interact with a patient. And kind of what's the goal of a mental status exam? After you're reading it, you should know exactly what it was like to be in the room. Was the patient lying a lot? Was the patient fidgety? Did the patient have abnormal movements? So you're really trying to capture what it was like in the interview. The other thing is, it's not necessarily the history of a patient. I kind of discussed this a few slides back. It really is. It's just a snapshot. If a patient is complaining of hallucinations, but when you're talking to them and you say, "Hey, are you having hallucinations now?" and they say no, that's what you document as. Okay, it's meant to aid in the monitoring and just seeing if things are fluctuating. But another thing that it isn't is some of these other screening tests that you might be familiar with. So a mini mental status exam is something that people often confuse when we talk about a regular mental status exam. So the mini mental state examination is something to help with screening for and diagnosing dementia. Okay, and also a MoCA test is a very similar thing, looking for levels of dementia and cognitive process. A PHQ-9, which is the patient health questionnaire with 9 different questions on it, that's more of a screening that we use in family medicine for just general depression and anxiety. And so how is a mental status exam used? Again, it really is a major part of basically every interaction we have with a patient. So, with an initial assessment, you might get to see an entire full H&P, but then there's also that MSE component in there too. But really, when I'm at the hospital, I'm doing the day-to-day, I'm just checking in on a patient that's already been there for several days, and I'm just checking in to make sure they're doing okay. I'm just going to do my mental status exam and then add on my assessment and plan afterward. Same thing with my outpatient follow-ups. I'm not going to be sitting there doing a full H&P on a patient every single time they come in, but I'm going to make sure I get my assessment of how the patient is doing that day, and then I'm going to figure out what the A&P is for. In general, on your initial visits, so the first time you meet a patient, you'll do your full H&P and MSE. So here's kind of the tricky thing. So mental status exams are different in the same way that questionnaires to patients, or how you do your HPI with a patient is different on the health provider. There's different mental status exams that are out there. They generally have the same qualities, but you'll see a lot of variations on the questions out there and how you even describe them. And then even if you do find things that are the same within a practice, let's say, health providers tend to use them differently. Okay, so that's another tricky thing about it too. I tend to use my mental status exam as something that's purely descriptive to really describe what's going on there, whereas some other people might only stray from a normal response if they feel like they're going to intervene or do a management or treatment on it. And again, that's just up to the health provider. The first major segment of the mental status exam is the general appearance. Okay, another caveat before we really get into the specifics of a mental status exam. This is one of those tricky parts in medicine where there's the chicken and egg phenomenon, where it's hard to really know what do you teach first versus another topic. Like for example, like, do you learn about antibiotics before you learn about infectious disease, or do you learn about infectious disease first? And I don't think there's a good answer. It's difficult. I mean, we're going to be talking about symptoms and descriptions before we talk about the diseases that cause them, right? A mental status exam is how we document and point towards schizophrenia or depression or anxiety, and we haven't really talked about those things yet. So it's going to be difficult to understand really the purpose of all these different things and all the terms that we're going through, but just kind of bear with me, I guess. A good example is flat affect. For those of us that are familiar with flat affect, we know that that's something that's seen a lot in patients with schizophrenia. It doesn't have to be all of them, and not everyone with a flat affect has schizophrenia. But unless you know what it is, there are just a couple words there. So, obviously I can't really go into all of the different manifestations of the disease now, because that's what we're going to do later on. So don't worry about not understanding all of the terms as we see them, but as some prominent examples come up, I'll go through them. And really, maybe it's less, the specific term general appearance, but more what's the general state of the patient and what's the appearance of the patient, right? They are kind of different things. So It's generally the first set of observation inquiries that you consider. So the things that we'll talk about are the patient's appearance, their behaviors, and when we talk about behaviors, it's different. It's not just, are they behaving? We'll get to that. We're also going to talk about the patient's attitude, their level of consciousness, and their orientation. And this one I think most people are familiar with when we talk about alertness and orientation. Okay, for appearance, first we kind of consider their age. Do they look like they're of age? Okay, the common thing is to say, oh, patient is 44-year-old male, but they look older than their stated age. It's just a way to kind of get their general health. Do they have a normal gait? Is their grooming appropriate? Do they seem hygienic, or are they disheveled? Are they wearing appropriate clothing for the weather outside or for the situation, or are they not? Right? I think that makes a big difference. If it's an outpatient situation and the patient walks in and they have clothes that don't fit the weather outside, you can kind of consider there might be something off. What is their poise, right? Are they able to handle what's going on? Are they dealing with the situation around them? Is there a lot of yelling or agitation? And then are they having any signs of anxiety? So are they fidgety? Are they sweating? Are they nervous? So for behaviors, and like I said, it really isn't just like, hey, is Johnny behaving, right? It's less are they well behaved, and it's more what are their behaviors. So here we're really talking about abnormal movements, agitation, and here agitation doesn't necessarily mean are they upset with you, but are they able to sit still? Okay. Rigidity, abnormal posturing movements. So this would be more related to things like side effects from medications or movement disorders. When we talk about the attitude, the easiest way to tell this is how do you feel when you're in with the patient? What was your experience? So were they friendly? Were they pleasant? Were they cooperative? Hostile, evasive, rude, guarded, suspicious, apathetic, easily distracted, focused, defensive? I mean, for me, the easiest way to think about this is, like I said, it's how did you feel when you were talking to the patient? Did you enjoy the conversation, or did you get annoyed, or did you get scared? That's really a good way to discuss this portion of the mental status exam, is how you felt. It's a little bit similar to transference, but we'll talk about that later. So alertness: vigilant, drowsy, asleep, comatose, confused, fluctuating, lethargic. And then just the questions we kind of ask. What is your full name? What day of the week is it? What time do you think it is? And what would you call this place right now? It's interesting. One of the things that I've noticed when you're doing this sort of interview is that if the patient is oriented, you're almost afraid to ask that question because it almost seems insulting, Whereas if your general sense is that this patient really is confused and has no idea where they're at, you have no problem asking that question. So it's kind of interesting, the kind of sense you can get from talking to someone without even knowing specifically what's going on. So an example of the things we just talked about: 51-year-old male, appears his age, he has a normal gait, appropriate grooming and clothing, no abnormal behaviors are noted, patient and pleasant and cooperative in the interview, alert and oriented to person, place, and time. And that's basically it. And again, most of those things are observed things. The only things that are really inquired are the orientation. Do they know where they're at? Do they know what time it is? And do they know their whole name? Some of the tips that are here, and this really is included for the entire mental status exam. It's try to avoid the word normal, right? And just be descriptive. When someone comes in and they have normal clothing on, that doesn't help you tell the picture of what's going on in that patient. If you say the patient is coming in with clothing that's appropriate to the weather, that at least tells you that you have a better sense of what's going on there. You can even describe the clothing. Patient is wearing sweatpants and a t-shirt. So just trying to avoid the word normal. It's not like you're going to get docked off points if you put normal in a mental status exam. It's just that you'll find that it'll help you more when you review your notes, right? If you say and then there's probably other examples that make more sense, like what's a normal mood? Well, the patient can say something like I'm tired, but that doesn't really say their mood. Mood is kind of like happy, mad, or sad. So a lot of times if I have patients that don't want to, not that they're trying to hide something from me, but they just say I'm tired and they don't want to go into it, or they just refuse to say they're happy or mad or sad, I just put that the patient doesn't state their mood. Okay. So yeah, always try to use quotes. The other tip is kind of always try to use quotes instead of interpreting the intent of what's going on. So again, if a patient says I'm tired, you just want to state that on there. The next section of the mental status exam is the mood and affect. And really, this is a paired inquiry and observation. So how does a person say they feel when you ask them? And to you, how does it seem like they feel? The mood is really, it's stated by the patient. So this is your inquiry. You say, how do you feel? And then you have it rank it. Well, I'm happy, and it's a 10 out of 10. This is the happiest I've ever been sitting in a room. And the different moods, obviously, happy, mad, sad, all these different things. When a patient tells you, oh, I'm just tired or something like that, and I always use this example because that's what everyone says. I always try to redirect them on that. I say, well, okay, fine. I understand that it means you say you're tired, but are you happy, mad, or sad? I really just try and redirect them to a mood, and it's actually you actually learn a lot from it, because generally, if someone is forced into saying happy, mad, and sad, and they're still not willing to say they're happy. So here's exactly how this happens. I say, how are you doing today? Well, I'm tired. Okay, well, would you say that you're happy, mad, or sad today? Well, I don't know, none of those things. Okay, well, are you mad about anything? No, I'm not mad. Are you sad about anything? No, I'm not sad about anything either. At that point, you can kind of see it's someone that's really unwilling to say they're happy. That happy is to them is something they're not willing to state because they have an interesting expectation of what happy is. I'm not saying that automatically means they get medication, but it's part of the cognitive, filter of like, gosh, if a person is doing okay, they seem like they're doing okay, they're joking with you, and they still can't say they're happy, what does that really mean with their, like I said, their filter on life? Now the affect. So this is the paired part that's an observation. So this is our expression of an emotion, right? It's our nonverbal way of expressing our emotions. So here, you have to observe, does the patient seem happy, angry, or mad, or sad when they tell you what their mood is, okay? So in addition to you kind of interpreting what their actual mood is by what their affect is, you also want to include these other modifiers. So let's say a person says they're happy. and you agree they're happy. Well, why do you agree with them? What are the things that are telling you that that person is actually happy? Well, here's where the modifiers come in. The first one here is the range of affect. Okay, so do they have an appropriate range? Does their voice go up and down? Does their volume get louder when they're trying to make a point? Does it get quieter when they seem to be shy about something? Do they smile? Do they not smile? Right? That's a big point too. If someone is constantly smiling, you'd be kind of concerned with that. So, you're looking to see if basically their physical manifestations go up and down with the moods as they're talking to you. So, do they have an appropriate range of mood? The other thing is the intensity. And this is the classic one that I think most people know about when they think of affect is, what is the intensity of their affect? Is it appropriate for their stated mood? Is it constricted? Constricted would be when you're talking to someone that's depressed, right? And they say, yeah, I'm doing okay. But you can tell they're really not, right? Their shoulders are slumped, their tone of voice is really monotone. So that would be constricted affect. Blunted would just be a worsening thing of that, where you really think, gosh, that person is, when was the last person that person had a good day? And then completely flat affect is something that you see in schizophrenics, where it's not just that they're not in a good mood, or it's beyond that. It's that there's a disconnect between their physical manifestations and their actual mood. And we'll talk more about that when we get to schizophrenia. And then the other thing you want to talk about is it congruent or incongruent with their mood? When they say they're happy, do they look happy? Or when they say they're sad, do they still look happy? Okay, so that's something you want to note also. Just a little aside, affect is an interesting thing. Like I said, it's not something that you think about. It just happens as you're going through life, right? You're expressing yourself, and so it's subtle and it's difficult to fake generally. Okay, if you look at this picture here, even though obviously they're being forced to smile, you can tell that Homer is like, he looks upset and the other guy looks frightened, right? So even though they've made the big obvious joke of making them smile, it was still easy to kind of convey other things about them. And that's just all about their brow line. So it's very subtle things that, we as human beings notice. So it's very connected to the brain, and it's very connected in a rationally thinking brain. So again, when I talk about schizophrenia and those people have really disordered thinking, it's not that they're choosing to have disordered affect. It's that their brain is not putting those things together. Like, it's very difficult to fake flat affect if you're trying to look like a schizophrenic. And it's very difficult when you're depressed to not look depressed. Okay, so affect is, even though it's just our interpretation, there's so many things that our brain does in order to really interpret all these subtle lines and features. It's basically, what a lot of people use to tell if you're lying or not, right? All the cop shows that are out there that talk about, when they're interviewing a witness, what are the things that they're doing? All these unconscious, subtle things are your affect. So here, well, this is a good example. Is this person happy, mad, angry, right? Hopefully you can see they're kind of angry. Then let's go here. So now what is this person? This person's sad. So it's interesting. They're very subtle things. I mean, we haven't shown any of the other features of this person's face other than these very rudimentary drawings of eyes. And like I said, they're very it's just such a small thing, but it conveys a lot of information. I mean, these are just two shapes. There's not even a real face here, and we can still tell. Our brain can interpret this affect correctly, unless you can't, right? And so that's one of the issues with maybe some types of autism that are out there, is that they're not able to process all of these different signs and signals. So patients, an example, patient states their mood is happy, a 7 out of 10 because I love my job. But what if it was this person talking to you and they had this sort of poise and stance and, so patient affect is sad with a restricted range, appropriate intensity, and is incongruent with their stated mood, which was happy. So that's how you would kind of document this affect and mood. So it's a nice thing because it's the connection between those two things. It doesn't just show you a level of cooperation. It's also just kind of what's going on with the patient. The next part of the mental status exam is speech. And really, I want to make sure that we understand what we're talking about here. It's not the content. We're going to talk about the content of someone's speech later on, because really, the content of someone's speech is more related to the way they're thinking, their cognition. So it doesn't belong in this section. This is just the quality of their speech. So it's similar to affect in that there are subtle changes in our speech quality that are subtle and difficult to fake. So as far as things that describe the quantity of our speech, being talkative, having a paucity of speech, spontaneous speech, needing prompting for speech, the rate can be fast, slow, or appropriate, or pressured, where they feel like they're just constantly talking all the time, and it's rapid, constant talking. It's not just fast. It's kind of like overlapping your speech and not letting you talk. Volume, loud, soft, monotone. So it's constantly the same volume. Fluency and rhythm. So do they have correct inflections based on, if they're asking questions or not? You can tell that my voice definitely goes up and down, has a specific inflection points to it. Are they hesitant when they talk? Again, not because they're hesitant because of the content, but do they always pause and then they start talking? And that's something that can be related to IQ, or just when you see it, it's noticeable. Their articulation, are they able to speak well? And then do they have any aphasia? Aphasias are generally organic issues with speech, but there's some special types that can be related to schizophrenia. So the example here, patient has spontaneous speech at appropriate rate, which is monotone with appropriate inflections and good articulation. I think the main question though is, did he really love Lily? Is that enough? I don't know.